Okay, this is Chapter 9, Hypertensive Complications of Pregnancy. We'll first start with overview of hypertension in pregnancy. Here's what we're going to look at in terms of our diagnosis: gestational hypertension, chronic hypertension superimposed preeclampsia, eclampsia, severe preeclampsia, and mild preeclampsia. I use the letters PIH as a contraction for preeclampsia. And our management may be outpatient conservative, inpatient and aggressive, or conservative. Let's start. What normally happens to blood pressure in pregnancy? Both systolic blood pressure and diastolic blood pressure decrease. And you notice even at the end of the pregnancy, even though the blood pressure comes up, it is never higher at the end of the pregnancy than it was prior to the pregnancy. Hypertension is never normal in pregnancy. The criteria that we use for hypertension is an absolute number, 140/90 or greater. In the past, in pregnancy, criteria have included a rise in the systolic of 30 millimeters of mercury or more, a rise in the diastolic of 15. That is no longer used. It is 140/90 only. The reason why hypertension is such an issue is that the vessels in the placenta constrict. And when you have constriction of blood vessels, you will get decreased blood flow, which translates then into decreased oxygen, decreased nutrition, and fetal jeopardy. All right, let's look at gestational hypertension. Here is our case. A 19-year-old Gravida 1 is seen in the outpatient prenatal clinic for a routine visit. She's 32 weeks, confirmed by first trimester ultrasound, so her dates are sure. She has no complaints. Specifically, the three things she denies is headache, epigastric pain, and visual disturbances. Those are something that we always need to ask in terms of preeclampsia. Headache, epigastric pain, visual changes. She has none of those. She's gained 2 pounds since her last visit 2 weeks ago. What should be the weight gain during pregnancy? 1 pound a week? Is that appropriate? Yes, she's right where she should be. Her blood pressure, however, is 155/95, so she meets the criteria for hypertension. But hypertension is not diagnosed on one blood pressure reading. You need to repeat it, and we repeated it, and it was still elevated 10 minutes later. Trace pedal edema, the significant finding on this case is, even though she has hypertension, she is negative in the urine for protein. Negative for protein. Gestational hypertension is defined as sustained elevation of blood pressure, but no proteinuria after 20 weeks gestation. Symptoms? None. Any physical exam findings? None. Unremarkable. All we have is isolated finding of hypertension without proteinuria. Gestation 20 weeks or more, sustained hypertension, no proteinuria, diagnosis, gestational hypertension. Now, after the pregnancy is over, and the patient had a diagnosis of gestational hypertension, if the blood pressure normalizes, in retrospect, we say this was transient hypertension. If during the pregnancy she had elevation of blood pressure, no proteinuria, but the blood pressure remains elevated, what we'll say is she probably had new onset of chronic hypertension that just happened to begin during the pregnancy. So gestational hypertension is a mixed bag, and it really is a statement that she developed hypertension in the last part of the pregnancy without proteinuria. Now, hypertension in pregnancy is linked to later cardiovascular events, just as patients who have gestational diabetes have a higher rate of type 2 diabetes later on. That's the end of gestational hypertension. Mild preeclampsia. Here is our case. 21-year-old gravida 1, seen in the outpatient clinic for routine visit at 32 weeks, confirmed by first trimester ultrasound. That's the same as our previous case. However, this patient complains of swelling in her hands and feet, but denies headache, epigastric pain, and visual changes. So she doesn't have those signs of severe preeclampsia. She's gained 10 pounds over 2 weeks. She should gain only 2 pounds in 2 weeks. So she's got increased weight gain. Her blood pressure is 155 over 95. That meets the criteria for hypertension. And it remains elevated 15 minutes later, shows she has sustained elevation of blood pressure. She has 3+ pedal edema, fingers are swollen, but the most significant finding is she has protein in the urine, 2+. No headache, epigastric pain, visual changes, mild elevation of blood pressure, and protein in the urine. That is consistent with preeclampsia. Gestation over 20 weeks, sustained hypertension, proteinuria equal to or greater than 300 milligrams in 24 hours, mild preeclampsia. A dipstick of urine is probably not as precise in terms of establishing proteinuria as is a 24-hour urine collection. And that's why we would prefer to do that. Less than 300 milligrams is considered not significant. 300 milligrams or more is. Notice the difference between gestational hypertension and mild preeclampsia. They both have their onset over 20 weeks. They both have sustained hypertension, but gestational hypertension has no proteinuria. Mild preeclampsia does have proteinuria. Demographics. Risk factors for preeclampsia, the most significant one is nullipara. A woman who has never gone beyond 20 weeks in her pregnancy has an 8 times higher risk of preeclampsia than a woman who's had previous term pregnancies. Age extremes, teenagers, advanced maternal age. Multiple gestation, we talked about that already. 3 times increased risk of preeclampsia. Molar pregnancy, now that's an interesting one because you can develop preeclampsia before 20 weeks with molar pregnancy. Non-immune eye drops. And notice these 4. Diabetes mellitus of long standing, chronic hypertension, renal disease, systemic lupus. What is it that ties these 4 together? Small vessel disease. Any patient who has small vessel disease, increased risk for preeclampsia. The pathophysiology is diffuse vasospasm. So throughout the body, the blood vessels narrow down. And that's one of the concerns, decreased perfusion. That can lead to capillary injury, and you can have then leakage of fluid from the intravascular space into the interstitium. Significant is that there are no symptoms. No headache, no epigastric pain, no visual changes. On exam, there really is no specific findings. Laboratory tests, what will we see? There must be protein in the urine to make a diagnosis of preeclampsia, 1 to 2+ or 300 milligrams on a 24-hour urine. And evidence of hemoconcentration. Instead of having the hemodilutional changes, such as a decreased hemoglobin, hematocrit, BUN, creatinine, and uric acid, we have a hemoglobin that's going up. It may be 13, 14. That's not normal. A BUN may be 15. A creatinine may be 1. Hemoconcentration we will see. What is a management for mild preeclampsia? If she is less than 36 weeks, we will hospitalize her inpatient and just conservative management until she gets to 36 weeks. The whole idea here is to give more time for el bebé. If she is 36 weeks or more, we want to deliver, and we want to prevent convulsions by using magnesium sulfate, and we will deliver her. No need for a cesarean delivery. We can have a vaginal delivery, and we want to continue the mag sulfate for 24 hours postpartum. This is magnesium sulfate. It is put on flowers. It is used to soak your foot if you've got a sliver in it. And many internal medicine people used to say, why don't you guys use a real anticonvulsant? The evidence, however, is overwhelming that magnesium sulfate in a head-to-head trial was better than phenytoin in preventing convulsions. If I had my way, I would rename preeclampsia, and I would call it diffuse vasospastic disease of pregnancy, because that's really what happens. Normally, you have vasodilation in pregnancy. That's why we have the drop in blood pressure, which normally and naturally occurs. But with preeclampsia, you have diffuse vasospasm. Instead of the blood vessels looking like this, they get constricted. Now, what is it that constricts the blood vessels like this? Not entirely clear, but there's good evidence that prostaglandins are involved. That thromboxane, which is a vasoconstrictor, goes up, and prostacyclin, which is a vasodilator, goes down. And that has led some people to think if we can suppress prostaglandin production with prostaglandin synthetase inhibitors, perhaps we can prevent preeclampsia. And some people have tried to do that using aspirin. Okay, and that is the end of mild preeclampsia. Now we move to severe preeclampsia. What happened to moderate preeclampsia? There is no moderate preeclampsia. It progresses from mild to severe. Mild is conservative management. Severe is going to be managed aggressively. And look at the difference in this case. 21-year-old gravida 1, 32 weeks gestation, confirmed by first trimester ultrasound, same as the previous one. But look at all of the evidences of severe preeclampsia. For 24 hours, she's had severe occipital headache. What part of the brain is hypoperfused most commonly with severe preeclampsia? It's going to be the posterior lobe, the occipital lobe. And that leads to then the visual changes. She's had mid-epigastric pain, not relieved by acetaminophen. What's a mid-epigastric pain? Swelling of Gleason's capsule of the liver. She sees light flashes and spots. Is your epinephrine level rising? Mine is, just from reading the case. She's gained 10 pounds in 2 weeks. Her blood pressure is 165/115. What is the upper limits of blood pressure in mild preeclampsia? Up to 160/110. Greater than that, it becomes severe preeclampsia. Now, I should say that in the past, preeclampsia has been identified as a triad: hypertension, proteinuria, and edema. The edema is no longer used for diagnosis of either mild or severe preeclampsia. And the reason is because you can have those without edema. You can have edema without preeclampsia. She has 3+ pedal edema. Her fingers are swollen, and I don't ignore that, but that is not necessary to make the diagnosis. Her fundal height is 29 centimeters. Now, she's 32 weeks. Is this appropriate? Well, it's a little small, but it's within the normal range of ±2 to 3 centimeters. Fetal heart tones are regular at 145 beats a minute, but notice her urine dipstick is 4+ protein. Headache, epigastric pain, light flashes, severe elevation of blood pressure, and 4+ protein in the urine. Okay, let's just review. What are the blood pressure criteria for severe preeclampsia? 160/110 or greater. What are the proteinuria criteria? 5 grams or more. So mild preeclampsia, 300 milligrams up to 5 grams. Severe preeclampsia, 5 grams or more. Symptoms: either the headache or epigastric pain or visual changes. Now, what's the most common cause of headache in pregnancy? Muscle contraction headache. That's not going to be an indication for delivery. This is a new headache, which is never had before. What's the most common cause of epigastric pain in pregnancy? Reflux esophagitis. We're not going to deliver a premature baby because of reflux esophagitis. But this is a new pain which doesn't respond to antacids. Visual changes. I had a patient once who was at 30 weeks gestation. She woke up in the morning. She couldn't see. She was blind. Her sister came and said, "You got to go see the doctor." "Yeah, but I got to get my hair done up." So her sister got her hair done up, made her put on her makeup. She comes to the emergency department. Who was the first consultant who was called? Ophthalmologist. Ophthalmologist looks in her eye, says, I don't see any problem there. Took her blood pressure, 210 over 140. Urine dipstick, 4+ protein. What has she got? She's got severe preeclampsia with nothing wrong with her eyes. This was a central problem in her occipital cortex. We went ahead and delivered her, and within 48 hours, her vision returned. Symptoms. Laboratory tests for severe preeclampsia. If you have evidence of DIC, decreased platelets, decreased fibrinogen, increased fibrin split products, prolonged PTT, that would be evidence of severe preeclampsia. Even if her hypertension is only mild, even if the proteinuria is even mild, if she's got any of these single ones, headache, epigastric pain, visual changes, DIC, elevated liver enzymes, ALT, AST, 5-gamma-GT, and so on, and pulmonary edema, oliguria, cyanosis. So even mild hypertension, mild proteinuria, in the presence of any one of these which reflect severe end organ involvement, that is severe preeclampsia. This slide shows the evidence of DIC on a peripheral smear, and you can see the schistocyte, the helmet cell, the fragmented red cell. Risk factors for severe preeclampsia are basically the same as mild preeclampsia, particularly patients who have small vessel disease, systemic lupus, type 1 diabetes, chronic hypertension. Those would be all candidates for severe preeclampsia. Most cases of severe preeclampsia are managed aggressively. Aggressive management, not conservative. That means we give intravenous mag sulfate to prevent convulsions, and we want to continue that for 24 hours postpartum. We want to lower the blood pressure. How far do we want to lower the blood pressure? Remember, in the physiology of pregnancy, the uterus is low on priorities. If push comes to shove, the woman is first going to send the blood to her brain, to her heart, to her kidneys. If anything is left over, the uterus will get it. So we don't want to lower the blood pressure down to normal levels. We want to bring the diastolic between 90 to 100, and we will use hydralazine or labetalol to do that. And then end the pregnancy, induce labor. If mom and fetus are stable, if they're unstable, then of course a cesarean. But not necessarily do we need to do a cesarean. So aggressive management with severe preeclampsia. There are few patients who you might manage conservatively. And these are patients who have no severe end organ effects. They have no headache, no epigastric pain, no visual changes, no DIC, no elevated liver enzymes, no oliguria, no pulmonary edema, no cyanosis. If they're between 26 and 34 weeks, we can lower the blood pressure below 160 over 110. We can put the patient in the ICU, monitor her closely, give her betamethasone to mature the fetal lungs, and continuous IV mag sulfate. If she's less than 26 weeks, there is no evidence of benefit. If she's over 34 weeks, there's no evidence of benefit. And the whole purpose here is to try to get more time for the baby. But remember, there has to be no evidence of severe end organ effects. And that is the end of severe preeclampsia. Remember, there's no moderate preeclampsia. If it's more than mild, it becomes severe. Now we move to chronic hypertension with or without superimposed preeclampsia. Chronic hypertension is diagnosed as blood pressure elevation either before 20 weeks gestation or prior to the onset of pregnancy. Here's our case. A 35-year-old multigravida is seen in the outpatient clinic for her first prenatal visit. I want you to notice the maternal age. With preeclampsia, more likely to be a young woman. With chronic hypertension, more likely to be an older patient. And here we have a 35-year-old. She is 12 weeks gestation with a blood pressure 155 over 95. Onset of blood pressure elevation, first trimester, chronic hypertension. Now, in her case, the chronic hypertension was diagnosed 5 years ago, so she had a pre-pregnancy diagnosis. She's been treated with oral nifedipine, a urine dipstick protein, 2+, so she's already got renal involvement. A recent 24-hour urine protein showed 1.2 grams of protein. Is that significant? Over 300 milligrams. Yes, it is. Her creatinine clearance is 85. Now, what is a normal creatinine in a non-pregnant woman? I should say creatinine clearance, 100 to 125. In a pregnant woman, it should be 150 to 180. This woman has less than half of that. Serum creatinine is 1.2, so she's got chronic hypertension with significant renal involvement. No headache, no visual changes. Diagnosis for chronic hypertension: gestation less than 20 weeks or pre-pregnancy with sustained elevation of blood pressure. There may or may not be proteinuria depending on the degree of involvement, but the key finding is when did the hypertension occur? Now, we have chronic hypertension which has a good prognosis, and that's typically patients who have mild elevation of blood pressure, anywhere between 140/90 to 179/109, and no end organ damage. No renal involvement, no involvement of the eyes, no involvement of the heart, left atrial hypertrophy. And these patients can often be managed conservatively and do well. Poor prognosis. The main organ systems we're concerned with is small vessel disease in the kidneys, the eyes, and the heart. If she has renal disease, creatinine over 1.4. If she has evidence of retinopathy from long-standing hypertension. If she has left ventricular hypertrophy because of the heart having to work against this high diastolic blood pressure. That's not so good. But the worst prognosis, uncontrolled hypertension, 250/140, or chronic hypertension with superimposed preeclampsia. Half of our maternal mortalities at Loma Linda University Medical Center have occurred in patients with chronic hypertension who already have vessel involvement and weakening, and then superimposed preeclampsia, and these patients, they blow out their brains. Intracerebral hemorrhage. That's a bad outcome. So, how do we make a diagnosis of chronic hypertension superimposed preeclampsia? I'm using PIH as an abbreviation for preeclampsia. She already has chronic hypertension. Blood pressure, instead of coming down, is going north. It's going higher. Proteinuria, either she had none and is developing it, or she's got it and it's getting worse. Chronic hypertension superimposed preeclampsia. How do we manage these patients? If it is uncomplicated chronic hypertension, and if her blood pressure is less than 100 diastolic, I'll even stop her antihypertensives and just follow her conservatively. If you need to use a medication, we will use alpha-methyl-dopa or Aldomet, not because it is the most effective medication, but has a track record of safety in pregnancy. We'll look for serial ultrasounds for fetal growth. Is there intrauterine growth restriction? And we'll do NSTs, AFIs after 30 weeks. If she develops superimposed preeclampsia, blood pressure going the wrong direction, protein getting worse, then that would be indication for delivery. If she's uncomplicated chronic hypertension, 40 weeks and let's get her delivered. I don't want to wait for superimposed preeclampsia to develop. Here's a couple of good board questions. What antihypertensive medicines should never be used in pregnancy? The first one is angiotensin-converting enzyme inhibitors. And the reason is fetal renal failure. So avoid those, stop them if she's pregnant. And diuretics, because diuretics, particularly if they're started during pregnancy, decrease the intravascular volume and then decrease the placental perfusion. If she is already on diuretics prior to the pregnancy, that initial decrease in intravascular volume has already taken place. But particularly with ACE inhibitors, we want to stop that as early as possible and not use them during pregnancy. Caution for ACE inhibitors in the first trimester. If there is chronic hypertension superimposed preeclampsia, we want to treat this patient aggressively. Prevent convulsions, intravenous magnesium sulfate. We want to lower the blood pressure to bring the diastolic between 90 and 100, and induce labor. Regardless of gestational age, we don't need to have a cesarean. Oxytocin amniotomy may be appropriate, but you don't want to sacrifice the mother and her health. And that is the end of chronic hypertension, with or without superimposed preeclampsia. The last topic in hypertensive disease of pregnancy is HELLP syndrome. HELLP syndrome stands for H, hemolysis, EL, elevated liver enzymes, LP, low platelets. So hemolysis, elevated liver enzymes, low platelets, HELLP syndrome. This is probably a subclassification of severe preeclampsia. And here's our case. A 32-year-old multigravida, 32 weeks gestation. On a routine prenatal visit, her blood pressure was 160 over 105. Now what's interesting, you can have HELLP syndrome without hypertension. Her previous blood pressures were normal. Her preeclampsia workup, where we drew blood tests, shows elevated total bilirubin. That would be an indicator of intravascular hemolysis. LDH is elevated, and that is often seen with hemolysis. ALT, AST, so we have elevated liver enzymes, and her platelet count is below 100 to 150,000. So she's got all three: hemolysis, elevated liver enzymes, low platelets. No headache, no visual changes. She's at 32 weeks. We're going to manage her aggressively. Intravenous mag sulfate, prevent convulsions. Induce labor, oxytocin amniotomy, if possible. Lower the blood pressure to between 90 and 100 diastolic with hydralazine or labetalol. And there is one other recommendation with HELLP syndrome, and that is to give the mom dexamethasone, not to enhance the fetal lung maturity, but to promote normalization of her liver function tests and of her platelet count. So that's going to be the management for HELLP syndrome. This table looks at the incidence of abruptio placenta, and normotensive patients and mild preeclamptic patients do not have any difference in abruption placenta. But notice severe preeclampsia, 10% of patients, eclampsia, 11%, chronic hypertension superimposed preeclampsia, 15%, but the highest risk of abruptio placenta is HELLP syndrome. Okay, let's summarize what we have just said. And this is our table. Our differential diagnosis is in the middle. Criteria for diagnosis on this side. Management is on this side. Notice proteinuria. No proteinuria, sustained elevation of blood pressure after 20 weeks. Diagnosis, gestational hypertension. If it is uncomplicated, conservative outpatient management. Chronic hypertension may or may not have proteinuria. Hypertension either prior to 20 weeks or pre-pregnancy. Management uncomplicated is conservative. If you need to use any medication, we're going to use alpha-methyl-dopa. If she has known chronic hypertension with blood pressure getting worse, proteinuria developing, that's chronic hypertension superimposed preeclampsia, this is what I call aggressive management. Inpatient, mag sulfate to prevent convulsions, lower the blood pressure to between 90 and 100 diastolic, and deliver by the appropriate route. If she has eclampsia, hypertension, proteinuria after 20 weeks, unexplained seizures, management, aggressive. If she has maternal or fetal jeopardy, plus hypertension, proteinuria, when I'm saying maternal fetal jeopardy, we're talking about end organ effects. Headache, epigastric pain, visual changes, elevated liver enzymes, DIC, oliguria, cyanosis, so on. She has severe preeclampsia. Management is aggressive. Mild preeclampsia, hypertension, yes. Mild proteinuria, yes, over 20 weeks, but no maternal or fetal jeopardy, no headache, epigastric pain, visual changes, DIC, elevated liver enzymes, etc. Management will be conservative if she is preterm, less than 36 weeks. If she is 36 weeks or more, give her magnesium to prevent convulsions and deliver by the appropriate route. And that brings us to the end of this chapter on hypertensive disorders of pregnancy.